Hi everyone, today we have this mandibular molar and we are going to do a live excess cavity preparation for this grossly carious mandibular molar. And the key things that we need to understand is when we are doing an excess cavity preparation for these type of tooth, we should have a good judgment of whether this tooth is the tooth that we can save, and with a proper diagnosis only we should proceed. So in this session we are going to go step by step and learn how and what are the crucial things that we need to do. We have a running poll that is ongoing, and the crucial steps during the excess cavity preparation of such type of molars. What is the most important thing amongst all? We should, or you should be able to understand and maybe pick up from that options whatever you feel. Now when planning the excess cavity preparation, we would go slowly, conserve the healthy tooth structure, remove the caries that is there, and identify the orifices, as many orifices as we can. So beginning step by step, we have this round diamond point and we are going to get into the excess. So let us proceed. So now you can see that we have started to remove the caries initially. So the first thing that we are doing is we are removing the caries. We are not just identifying the orifices, we are just going to remove all the caries that is there. So as you can see that we have removed the caries and we are able to easily find out the canal orifices. You can clearly see the canal orifices when we have removed all the caries. We are trying to maintain the healthy tooth structure in and around. So these walls are a little fragile to break, so we should be able to just remove these as we need the reference point, and once we enter with the endodontic file, these reference points are weak, so we should be able to remove these reference point and maintain a healthy tooth structure or the sound tooth structure as much we can, which would act as a reference point. So for the same, we can begin with the AtoZ bar. So here we have this AtoZ bar and we are just removing the weakened tooth structure that we have. Now you can visually see that we could maintain the healthy tooth structure. We could identify the canal orifices. This is the distal canal orifice over here, a large one. Then there is the mesial canal orifice. This is the mesobuccal canal orifice. This is the mesolingual canal orifice. And this is the dentinal map that we can see. So this is how we are maintaining the healthy tooth structure. We have identified the canal orifices inside, constrained inside in the central area that we have. There is no pulp tissue. This has regressed, and this should be the approach. If you feel like that there is any brittle structure or the reference point is liable to break, you can just have the healthy tooth structure and then proceed with your identification of the canal orifices and further. Thanks for the question. There is a question that when do I stop digging the tooth? Yes, it is important to understand. Thanks for asking, doctor. So whenever we are entering inside the tooth, we would feel the burr drop. That is, the burr would easily go inside from the roof of the pulp chamber. At that particular point of time, do not use the round diamond point. Instead, switch to the AtoZ burr. You would feel a burr drop. See, when you are doing the access cavity preparation on the floor, you would immediately get a drop. That is, the burr would go freely inside. Once you feel that then at that point of time you switch on to this AtoZ burr. This AtoZ burr is having a cutting fluids at the lateral aspect, and there is a round tip which would not perforate the floor of the pulp chamber. Even if I need to move it on the floor, see, I will move it on the floor and it would not perforate it. How much I move it, this will not perforate the pulpal floor. This has the lateral cutting fluid, but it would not do anything to the orifices. It would not hurt the orifices. So do not use the round point or the round diamond point. Instead, use the AtoZ burr. Hope you get my point, doctor, that the digging that you were talking about is once you are opening or going inside in the central area or at the centralmost point, you would feel the burr go freely inside in one go at one particular point. That is, you have entered into the pulpal chamber from the roof of the pulp chamber. So this was the point. Hope I was able to clear it. So this is how our access cavity would look like once we have identified it. Now for the next step, we are going to move on to the identification that we have already done. So we would next determine the working length. Before that, what we can do is an initial approach that we can follow is we can just use a negotiating file like a 10K file or a 15K file. Since these canals look a little larger, so we can use these reamers. Let me show you the reamers. This is a 15K reamer. So what we are going to do is a larger canal, then clean the fluids of the reamer, then identify or negotiate this mesobuccal canal. As much as the file can go, do not press it as you still don't have the working length. Then use the reamer again and go inside the mesolingual canal orifice. So you could easily negotiate all these canals, and once you have negotiated, you have entered with the file. This is the time you would initially irrigate your root canals with the first irrigant, that is the sodium hypochlorite. Start using the sodium hypochlorite initially only with a side vent needle. So this is a side vent needle. See, this is a side vent needle, and with this needle you are going to initially introduce it into the canal orifices. We have yet not determined the working length. Once you irrigate with sodium hypochlorite, the next irrigant that you may use is saline as an intermittent irrigant. Do not blow directly, blow horizontally if you need to. That would be sufficient. These canals have irrigant inside, nothing to worry, just flush out the sodium hypochlorite with saline and again re-irrigate. So now the second irrigant would be the saline with a side vent needle. And I would like to ask you, why could be the first irrigant as sodium hypochlorite? And this sodium hypochlorite should be freshly poured from the bottle into the container that you are using, and it should not be kept well before the patient's access opening has been started. The freshly poured sodium hypochlorite would take around 15 to 20 minutes to effectively get the organic debris dissolved or necrose. So this is how you would flush out the sodium hypochlorite and with the saline, and then this is the time you can proceed with working length determination. And this working length can be determined with the help of the electronic apex locator. So this would be covered up in the next session that would be scheduled today. So hope you were able to identify that what we did in this access cavity preparation. We removed initially all the caries that we could suspect. The second thing is we could maintain the healthy tooth structure to have a good reference point for the working length and the working preparation. The third was to identify all the canal orifices, as many as we can, and then we negotiated the canals. And now is the time to proceed with the working length determination with the help of electronic apex locator. So hope the things were clear to you, and we would be back in the next session. Till then, goodbye.